Hi, this is Emily Freeze. I'm a social worker from Brookdale Hospice in Wayne, Pennsylvania, and I'm just going to do a video quickly about how I would do a program explanation for a patient or family that's interested in our services and coming on to hospice. A lot of times it's the nurse or the social worker that sits down with the patient or family before they come onto service and provides this explanation, but I think it's really important for all of our staff members to be familiar with how to provide that explanation of benefits. As a newer staff member, I felt it was really important to get familiar with our admission book right here. And so I think all of our new hires should be reading that and familiarizing ourselves with it. But I also found it really important when I started to sit down, when I sat down with the patient and family, I had a copy for myself as well as giving one to them. It really helped me in guiding the conversation so I didn't forget anything. It's just a thorough explanation is super important so that a patient and family know what to expect from our services. So hospice care is end-of-life care. So when somebody wants to come on hospice, it is about seeking comfort instead of curing. To be eligible for hospice, a doctor has to certify that a patient might have 6 months or less to live if the disease runs its normal course. This doesn't mean that the patient is going to die within 6 months, but as Medicare is requiring us to do end-of-life care, provide end-of-life care for hospice, the hospice team has to document that there has been some kind of decline for somebody to remain eligible for hospice. So hospice is designed for comfort at the end of life. Also for people that, tired of going back and forth to the hospital. It's really important for a patient and family to know that we're not going to continue to seek aggressive treatment. Hospice is the new 911, that instead of going to the hospital, instead of calling the ambulance, you're going to call hospice instead. So it's important for patient and family to be comfortable with that and to understand that from the start. It is difficult for some people to wrap their head around that, and for me, I usually launch into the what ifs. If somebody falls and they need to go to the hospital because they need stitches or something, that's going to be okay, but please call hospice first and we will tell them what to do. It's generally a problem when a patient has to go to the hospital and then the family or the patient decides to be admitted to the hospital and seek treatment. That is when we would have to talk about revoking hospice benefits. And if that does happen and, God forbid, somebody breaks their hip and the patient or family decides to go to the hospital and get surgery, they have the right to do that. Absolutely. You can come off hospice at any time by signing the revocation paperwork. So if you change your mind, it's something that somebody is absolutely locked into. So sometimes we think that we're ready for hospice, and sometimes we're not. But I think it's important to address that with our patients and families. So what is hospice? That is the biggest thing that we need to explain to our patients and families. So just making sure that they know that it's about seeking comfort and not curing, but it's also, we have a team that is going to help them through the end of life and focus on quality of life and enjoying the time that they have left with their family. We treat the person and not the disease, and we focus on care and not the cure. And a lot of times people think that hospice is in the home 24/7. A lot of times people just have that connotation of hospice that, oh, you're not going to be here all the time. And that's not true, but we are available 24/7. So in the middle of the night, if there's a question or a concern or having trouble breathing or that kind of thing, a nurse is always on call. We also have a psychosocial team member on call for emotional support if needed. That would be the chaplain or the social worker or the music therapist. There's always a hospice team available to you 24 hours of the day. So I just want to talk about the services. I already said about the nursing, but we do have nurses, we have home health aides, we have the social worker, we have music therapist, volunteer, and chaplain. It is a whole team approach, and you don't need anybody in your home that you don't want in your home. So I want you to know that. I think it's super important for everybody to feel comfortable with the team members, but the only person that is required to come into the home and see the patient is the nurse. Now we also have aides that can help with activities of daily living and bathing, eating, getting dressed, also some light housekeeping. The nurses are typically involved if somebody is stable and not declining rapidly or in the active phase of dying. Routine nursing visits are typically 2 or 3 times a week, and the visits are generally an hour or less. It's not, they're not there all day. Same with the aides. The aides are task-oriented and have a plan of care that you and the nurse and the aide will work out, whether it needs showering, bathing, that kind of thing. And they're task-oriented, and so they don't have a specific time frame on how many hours they have to be there. They need to do their plan of care. We also have social work. Typically, social workers visit two times a month, but more if needed, depending on the family situation or emotional needs. Also, just as the nurse would increase at end of life, the nurse would increase to daily visits when somebody is entering the last days of their life. Social worker is expected to do the same if the patient and family wants that. The chaplain is available as well and can set up a time to come and chat about spiritual concerns that the patient may have, and it can set up the frequency of how many times a month that you would like that. Again, with the social work and chaplain and our music therapist, who is wonderful at playing guitar and singing and reminiscing and life review, you can set up with them how often you want them in the home. But for nursing, like I said, it's like 2 to 3 times a week to start out, more when necessary. For the aides, 5 times a week generally, or less if you need them. And we will work on timing of the day, which is most helpful to you. The nurse and the hospice aide can work on that. We also provide volunteer services for companionship and respite care for caregivers. If a caregiver has to go to an appointment or just needs a break to go to the store, that kind of thing. Just to have another face and somebody to listen to. We do have the volunteer services available as well. All of our team is under the direction of our medical director. You're more than welcome to keep your primary care physician as your main healthcare provider. You're not going to be going out to see them anymore, but everything that the nurse does and the other team members is approved by the doctor. The nurse would send recommendations for medication changes, and everything is overseen by the primary care physician or our medical director. As a hospice team, we meet every other week to discuss plan of care for all of our patients, so we're all on the same board, same team, and we just are able to communicate about the best plan of care for each of our patients. If there is a need for physical or occupational or speech therapy, we do have team members that we can rely on for that. Generally, for physical therapy and occupational therapy and speech therapy, we don't have regular visits, but they're there on a as-needed basis for safety. If somebody is having a lot of falls or something like that, an occupational therapist or a physical therapist can come out and show them safer ways to transfer or evaluate how our team members need to help them remain safe in their homes. As well as the chaplain services, we have our bereavement coordinator who is able to follow you for 12 months after the patient has died. So I think this is a super important part of our hospice team, that even after your loved one or patient has died, that the support still continues. And they will check in, the bereavement counselor will check in with you to make sure that you're doing okay. And of course, all of these services are voluntary. Like I said, the only person that you do need to have in your home is the nurse, which is super important for you to communicate what you are comfortable with, and just let the team members know on how you would like to best be supported. There are different levels of care of hospice, and generally we do keep patients in the home, and that is called routine home care. If there is an acute need, really can't be managed at home, we do have inpatient care available that you would go to a hospice facility that provides that inpatient care. We do have a contract with Seasons Hospice Palliative Care in Phoenixville Hospital. We also have the respite benefit, so this is really important, especially for home patients where a caregiver needs a break or needs to go on vacation, or God forbid the caregiver's sick. The respite benefit covers 5 days, 5 midnights actually, just like a hospital. That 5 days of care for respite for the patient to go to a skilled nursing facility. I do ask that as a social worker, I'm involved in setting up respite care. And if there is a vacation or something coming down the pike, it's really important to communicate to the hospice team about that. But obviously there's emergency situations where we need to get respite care in place quickly. In that case, we would go to the closest respite care facility that we may have a contract with, because we have to have a contract to have somebody have respite care there, but we would work it out if there is a need immediately. Continuous home care is also another level of care that can be provided. If the patient doesn't require to go inpatient, but there is a need, some unmanaged symptoms or crisis happening, that we would not leave. A nurse, if there are unmanaged symptoms, generally a nurse is only going to be in your home for an hour or less on a routine visit. But if there is a need and the patient is not comfortable, the nurse is going to stay there as long as needed to provide that care. So that's what we would call continuous home care, that it's a minimum of 8 hours of care per day. So the hospice aides or homemakers can help with supplementing that nurse's care so that there's somebody there helping to manage the symptoms. So it's basically the same thing as inpatient care, but it's done in the home, if that is a possibility. At the beginning, I talked about what the criteria is, about 6 months or less to live, and the agreement with hospice philosophy of comfort versus curing. As it is end of life, Medicare, it's a free benefit. Hospice is, if you're on Medicare, it is a free benefit for all those that are on Medicare. But Medicare also requires the team members to document a decline. And there are benefit periods that we say that you are still eligible. So there's unlimited benefit periods for hospice care. The first benefit period is 90 days, the second is 90 days, and then after that there's 60 days. So a doctor has to certify at those times that the patient is still eligible for hospice care, and that's where the documentation of the hospice team really comes into play. If we're not seeing any decline, if the patient has stabilized or even gotten better, because sometimes that does happen, we are going to have to discharge for extended prognosis. And in reality, while it is a little bit sad sometimes for our patients to be discharged, if that's the worst thing that happens, that's not so bad. We kind of call it graduating from hospice care. But we would absolutely give you warning on that and provide any resources that you may need to help out. There's so much benefit to hospice, having hospice in your home, having the team members supporting you. Medicare also helps pay for medications that you may be on related to your diagnosis. Like vitamins and supplements, that kind of thing aren't going to be covered, but anything related to the terminal diagnosis is going to be provided under the Medicare benefit. We also provide incontinence supplies and DME, the durable medical equipment like a hospital bed and a wheelchair and walker, that kind of thing that is needed for quality of life. So the hospice team, we are just here to support you in any physical, emotional, spiritual needs that you have, and at this time of life, it is a very difficult time in life for some people, and we just want to be here for any needs that you may have, in any way that we can make the quality of your life better and more comfortable as we can. So if I have any questions or concerns, you can always call our office. I'll give you information for our on-call services. Typically our hours are 8 to 5 every day. That's when the normal staff members are on call all day. But after 5, it will go to answering service, and the on-call nurse or the on-call psychosocial team member will be available to you at that time. So Thank you guys for listening to this. If you have any questions or concerns, please let me know. I am willing to help you out in providing this program explanation to patients and families, and I hope that you feel a little bit more comfortable in providing your next explanation.